The symptoms of dementia are very different for everybody. Depending on what stage you're in, depending on what type of dementia you have, yes, there are multiple types of dementia. In fact, there are over 50 known types of dementia that are out there. Certainly Alzheimer's is the most common, but many other types of dementia come about for different reasons. Dementia generally describes a group of symptoms that affect thinking, social ability, severely enough to actually interfere with their overall functioning. There are generally 2 or more critical areas that are affected, and of those 2 areas it's generally thinking, memory, language, problem solving, attention, and you think about just having one deficit in those areas, imagine what your life would be like. Now everyone who has dementia has at least 2 of those. Dementia affects seniors at different ages. There's actually something called early onset dementia that affects those that are younger than the age of 65. About 5% of new diagnoses of dementia are actually with the early onset. Dementia is actually the 6th leading cause of death in the US, and it's actually the only cause of death that is not preventable, curable, or the ability to be slowed. And so when we think about that, we're actually at this state of crisis in that we need to focus a lot of attention on finding a cure and finding the ability to slow the progression of the disease process. Many times people ask me about the ability to definitively diagnose dementia. Right now, physicians make those diagnoses based on symptoms. And that's why when you're speaking with your physician about what you're seeing, don't leave anything out. Be sure that you're telling them about every aspect that just doesn't seem right, because all of those symptoms have meaning. The interesting thing about Alzheimer's that I find is it actually changes the structure of your brain. It's not something that it's just these symptoms. It actually physically affects the size of the brain. Depending on the location of where the dementia is affecting you in your brain, those are the types of symptoms that we'll see. So for example, if you have frontal lobe dementia, you're going to see challenges with judgment and reasoning. If you have temporal dementia, you're going to see language barriers. And so those different types of dementia bring about different symptoms and behavioral tendencies. And with that, then, if we know those things, we can help be proactive in developing a service plan that is specifically tailored to that individual's needs. And then those things make sense. Alzheimer's disease is a progressive disease, as is most forms of dementia. What that means is that you'll start off with a diagnosis at a certain point, and then we just know that progressively more and more symptoms are going to come about. The first stage of dementia is generally 2 to 4 years, and certainly that can vary with everyone. A lot of times these folks are still living at home. They might begin to have more trouble with their finances and paying bills on time. We might see them isolating themselves a little bit more. Maybe when you're out at family functions, that individual may shy away from being in big groups because the commotion and all the sounds, it's hard for them to sort out all of that, and it's very overstimulating. There might be some confusion about time of day or what day of the week it is. You are definitely starting to see signs that there's something that might not be right. This is generally where we start seeking out some additional support from a physician, and you might actually obtain a diagnosis of dementia at this point. During the second stage of dementia, which typically lasts between 2 and 10 years, what we see a lot with that group is that they're getting to the point where safety awareness may be affected, judgment and reasoning. They may want to wear the same clothes every day because they don't realize that they wore it the day before, and they remember that, and that's what's comfortable. They may not want to bathe anymore. They may not want to take medications, or they may start getting them mixed up. This is generally when families start coming to us and saying, we need some help. And sometimes families are at a point of crisis and we need to get this individual some help right now. And sometimes it may just be a precursor. We've got some supportive services coming in at home, but this is what we see in the future. One of the things about Alzheimer's and dementia is that it affects physical functioning at different stages. And so usually when we start to see the need for that additional support is when the individual may need to have more help for the restroom. They may start to have some incontinence, and those things are really tough to manage at home. And this is also the point where we also see caregiver strain coming in. And families have been providing this additional support for so long, and it is such a burden. We don't want to look at it as a burden, but it really kind of overtakes your life. And it's important that you're able to just be a spouse again, or you're able to just be a daughter or a son and focus on that relationship that you have with that individual as opposed to being their caregiver. And that's where we come in. We're able to pick up those services and provide that supportive environment so that then you can just be that family member or that friend. Another thing that we see during the second stage of dementia is the beginning of what's called sundowning. And sundowning is a change of behavior, it's restlessness, it's anxiety. It affects everyone differently, but generally we start to see it happening about 1 or 2 o'clock in the afternoon, and it progressively gets worse as the day carries on. And so what happens is we usually see that the best time of day for this group of people is in the morning. This is when they're most alert. This is when they have the most energy. This is when they're the happiest, the most content. And so we try and work in things like exercise programs and trivia and things that can really stimulate them when they're at their best. And then we want to make sure that we're supporting them during that time of sundowning with calming social events and things that are hopefully going to not be too stimulating, because that just makes it worse. And so all of our programming in our Footsteps environment is tailored towards the time of day and the abilities of each individual person. The third stage of dementia, or sometimes called end-stage dementia, is actually lasts about 1 to 3 years. And again, it varies for everyone what the length of the stage is. But I have to say, in my experience of working with people with dementia, this is one of the most challenging stages for families. And the reason why it's the most challenging is because your loved one is here with you. They are physically present here with you. However, they may not remember who you are. They may or may not be able to respond to you and communicate with you. They are requiring almost total support for their activities of daily living or all of their care needs. You're actually at a point where you're almost grieving the loss while they're still here. And that's a very, very challenging stage for loved ones in particular. And our role turns to making sure that the resident has the best quality of life within that. And so we do things such as music therapy. We look at sensory involvement, things that can still stimulate them and provide them comfort, but just know that you being there with them and spending time with them is still a comfort, and you talking with them is still important. Just because they may not be able to respond back, there is no evidence to show how much they can comprehend and take in. So it's important to continue to communicate with them just as you always have. Your presence means a lot to them. During the final stages of dementia, generally what we see is that our residents typically have a lot more trouble with swallowing. And because of that swallowing difficulty, certainly their nutrition is affected. And we start to see a loss of weight. They may not be as mobile as they used to be. A lot of times people in the final stages are wheelchair bound. They're not able to get up and walk around anymore. And it's because of where the dementia actually affects their brain. It's not sending messages to the body properly anymore. With certain types of dementia, one of the things that we see is what we call shuffling gait. And what that is when you're walking and you don't really pick up your feet, you kind of drag your feet while you're walking. And we see with folks who have Lewy body dementia and sometimes that frontal lobe dementia that they definitely have that shuffling gait, certainly predisposing them to a very increased risk of falling. When you think about the purpose for memory care, we're talking about individuals who have moderate to severe memory impairment. And memory care is a place of social acceptance. The great thing about memory care is everybody's best friends. Everybody gets along. Nobody's being ridiculed. Nobody's thinking, well, that person doesn't fit in here. Another reason for being ready for memory care is a decreased safety awareness. You may not recognize that if I go out these doors, I can't remember how to get back. And so one of the things that our memory care offers is a supportive, secured area. And the very first thing that family members always say is, well, I don't want my loved one in a locked area. Well, here's what I'll say to that. The secured area promotes freedom. The secured area is a natural way for people to meander around our large spaces, because now they have the freedom to be able to roam wherever they want without somebody coming up and saying, no, you can't go there. All of that is perfectly acceptable in this environment, whereas it might not be in another environment. I think one of the biggest things that I find as the reason for footsteps that many people probably don't see until they get in there is how it improves their overall dignity and that level of social acceptance and feeling like they belong to that family. Because all of our activities are tailor-made to residents with cognitive declines. We focus on their abilities, not on their disabilities. Whereas if you have dementia and you're out in the public or you're in assisted living and there are certain things that you can't do, how do you feel? We want people to feel as though they are accepted. We want people to feel as though they can conquer the world. We can help them focus on the things that they're still able to do and feel really good about their abilities. One of the ways that we as a nursing team help to determine what level of care is appropriate and how much of a cognitive decline is there is by using different tests. There are certain assessments that are out there. One is called the mini mental exam. Another one is called the FAST exam, which is the functional assessment staging tool. And that helps to tell us where is their cognition at from a baseline standpoint so that we can then see over time where we're at in the progression of the disease process. Many times families want to know, how is my mom doing? You know, where do you see she's at? I mean, are we in the middle stage? Are we in the first stage? Where are we at? And using these tools can help us identify how far along they've advanced in the process and, you know, help give some indication of what abilities we can probably expect to see declining in the near future. Because it's not as if all of a sudden you just lose the ability to walk or you just lose the ability to button your shirt. It's fluctuating needs. So one day you may be able to do these things and the another day you won't. And sometimes that's very difficult for people to understand. And sometimes it's referred to as the good days versus the bad days. These fluctuating needs are sometimes hard to decipher if they're not in an environment that's very supportive of that, and knowing that in the morning, I may be able to do everything for myself, but by the evening, I'm pretty dependent on people because I'm now sundowning. I'm more anxious, more paranoid of who you are. I'm not sure who you are, even though you cared for me every day for the last 2 years, I still don't know who you are. And so our staff are specially trained to earn their trust with every interaction. Every interaction, I have to become your new best friend, so that you trust me enough to be able to care for you. And that's how we use our best friends philosophy as far as our footsteps goes, to provide that care and get things accomplished that just your average caregiver may not be able to do. All of our caregivers are trained in the CARES approach, not only before they get assigned to our memory care area, but along the way we provide additional training. We want to be sure that they have the support and resources available to deal with these challenging situations as they come up. To describe the CARES approach, I'm going to tell you a story about John. John's wife came to us just like many other family members do, very distraught, very upset, because the environment that he was living in at the time, the care facility, had just told her that he could no longer stay there. He was going in and out of people's apartments. He was going and grabbing things off of their bedside tables and rummaging through their drawers, and it was very intrusive to the people who were living there, and he was getting very angry. He would come out and start yelling at the staff, and it was just very clear that from a social standpoint he didn't fit in, and they didn't have the appropriate supportive area to be able to offer him more care and the care that he needed. And so as we began talking about what his care needs were, we want to know a little bit more about John. And so part of that is doing what we do with all of our residents, which is our personal history questionnaire. And as we worked through that, I asked her questions like, how long have you been married? And she told me that they were coming up on 50 years. I asked her, how many children did you have? Well, they had 3 children, and she told me a little bit about them. I asked about the things that they did for fun, and she told me about they'd go sailing. And then I asked, what did he do for a living? John was a doctor. And what John was doing is he was doing rounds. He was going in and out of people's apartments just like he would have in the hospital setting. And he wanted to go in and check on his patients. And see, when people aren't in the right environment and they can't drill down to all behavior has meaning. So what is it that is causing this behavior? Why is he doing this? And that's why that personal history is so critical to what we do. In his mind, he's back 40, 50 years old, and he needs to get his work done so that he can get home to his family. And nobody around is supporting him, because back in those days, the nurses went on rounds with him. So that's what we did. When he moved in with us, we had a chart available for him, and he would take that and go into people's apartments, and he'd make his notes on his chart. And you know, over time, he stopped doing that, but it's what provided him comfort at that time, because in his mind, he needed to get that done. One of the things that I see so often in someone who isn't trained on how to communicate with those with dementia is that using that word no. What we try to do is find a way to redirect without using the word no. And so, for example, someone wants to leave. They're over, they're at the door, they're pushing on the bar, they're trying to get out and they want to leave. I'm not going to walk up to them and say, you know what? You can't leave here. This is your home now. Well, what are they going to say? They're going to say, who are you to tell me that I can't leave? And so what we try to do is we go up and we ask them questions. The greatest way to communicate with somebody who wants to do something that you don't want them to do, ask questions. Try and figure out what they're trying to do. What is their motive? Where are they trying to go? Well, if they, in this instance, well, I want to leave. I want to go home. Oh, you want to go home? Well, how are you going to get to your home? Oh, well, the bus is going to come and get me. Oh my goodness, you haven't heard. The bus is actually, they called here about 10 minutes ago, because I know you had called ahead or somebody had called ahead for you, right? They are held up. There was a huge accident out on the interstate and they're not going to be here for quite a while. Okay, now what? Now they're trying to figure out what we should do. Well, I have a plan. And so we help them get turned around. You know what, while we wait for the bus, why don't we come over here and have something to eat? We've got cookies in the oven. We'd love for you to join us. And really, when it comes down to it, all we want our residents to do is just stay with us just a little bit longer. So what we do is we try and first connect with that person. If all behavior has meaning, what is the meaning of the behavior we're seeing? Not only knowing what the behavior is, but also knowing what time of day is it happening. Are there any trigger points that cause the behavior to happen? We have to kind of drill it down, and then we have to figure out how are we going to respond. It's trial and error. We don't always get it on the first try. But what do we do that helps to de-escalate those behaviors? And sometimes it's just redirecting them and getting them involved in something else. Sometimes it's getting them something to eat. Sometimes, like John, it's going on rounds and figuring out what it is that he's trying to do and helping to support him to do it. And then beyond that, it's making sure that we evaluate if it's working or not, changing the plan if it needs to. And the biggest part about it is sharing that evidence of what's worked with everybody. And that's not just our caregivers and nurses, that's the family too. We have a high staff to resident ratio. And because of the challenges that come along with having dementia, we have found that certain ratios work better in this environment than what they would in our other traditional assisted living environment. Memory care is a very low stimulus area. We may have a little more high activity in the morning when people are a little more alert. But then in the afternoons, things calm down. In fact, sometimes we find that even just turning the light levels down helps to calm people. In some of our memory care environments, we actually have adjustable lighting to help managing day and night, because that's one of the biggest things that we see that residents struggle with. So how do we help curb that? Well, we want to have as much natural light in as possible. We want to help emulate the outdoors and get people outdoors so that their brain can see, oh, it's daytime, I should be awake now, and help keep them awake. And then during the evening hours, we want to calm things down and help people know it's time to get ready for bed. Having that special activity programming that is really tailor-made to the different stages of dementia. And our staff are highly trained to help understand what that means. And so if I have the ability to do crafts, do things with my hands, then those are the types of things that we're going to do with them, whereas there may be a population of people in our memory care that they don't have the ability to do that anymore. So what types of activities can we tailor fit to them? And it may be more of the music therapy, or we may have some baking type activities where they can smell the aromas. Having children come in. Children are such a therapeutic mechanism for improving quality of life. Between children and pets, I don't know what brings a bigger smile to our residents' faces. Everything has meaning. There's strategically placed seating areas all around our memory care, and that's because we know that people like to meander the halls, walk, and when I'm tired, so I want to sit down. And so we try and have benches or chairs scattered all throughout the memory care. The lighting levels are low. We have sconces on the walls that help to provide the right ambiance and feeling so that it's not this bright fluorescent lighting on them, but it's a soft lighting. Comfortable furniture, all of those things make me think of home. They don't make me feel as though I'm somewhere else. They make me feel as though I'm in my own home. We eat in a family style dining, just like you would sitting around your own table. That type of an environment makes me feel comfortable. I feel good when I walk into our memory care. It's calming, it's comfortable, I feel safe, and it's fun. And that's really a place that we all want to be.